Okay, Mr. Smith, since we're going to do the NG tube, I need to take a look at your nose really closely, okay? I'm just looking to make sure that he doesn't have any septal defects that I can see very closely. Sometimes you're not going to know what the inside of the nose looks, but you do want to make sure that you take a look before you start. You want to see if one's bigger than the other and which side might be easier to place the NG tube. The other thing is we want to take a listen to his vowel sounds before we do anything. Sorry, sir.
What kind of vowel sounds were you looking for?
We're looking for hypoactive vowel sounds. Of course, that's not what we want to hear, but generally when they have a small vowel obstruction, you are going to usually hear hypoactive vowel sounds. Generally, to describe them as hypoactive vowel sounds, you are supposed to listen to each quadrant for 5 minutes. So this assessment would take you a minimum of 22 minutes if you are checking the nares and listening to your 4 quadrants. They try to tell us that you're going to hear these sounds in these quadrants. Well, everybody is different size and different shape. Obviously, if you have somebody who's 80 pounds, you know, you're going to hear vowel sounds from below all the way up at the top. And sometimes you're going to be able to hear vowel sounds when you're listening to their heart because they're so tiny. And then you're going to have patients that are obese, and it's harder to hear anyway. So just try to listen, try to see what you hear, and if you don't know what you're hearing, you know, always contact one of your more senior nurses.
What if you don't hear anything?
If you don't hear anything, absent vowel sounds usually means paralytic ileus of some type, and you know, the NG tube is still treatment for that. All right, Mr. Smith, I need you to take a few sips of this water. There you go. It's about 3 ounces of water that we're using to make sure that he can swallow prior to this so that we don't have any aspiration. Now, Mr. Smith, while we're putting in the NG tube, I'm going to ask you to try to keep your hands down. I know you're going to want to try to grab that tube, but please don't. If you do feel like you need to stop, you can just lift your hands for me, okay? Bowman. Hi, Mr. Smith. It's Tammy, your night shift nurse. I was coming in because your doctor said that you're going to need an NG tube tonight. I know that he talked to you about your small bowel obstruction, which is why you need the NG tube. Small bowel obstruction can be a blockage in the small bowel that is not allowing anything to pass, and a lot of times we need to put in a tube and suck all of that out. Sometimes you can have an ileus, which can require an NG tube, and sometimes you need decompression of the stomach, and you can use an NG tube. And then also sometimes surgeons will put in a NG tube for bowel rest after an extensive surgery, because it keeps the intestines decompressed, because they do create air, and gives the bowel an opportunity to rest and to heal. And generally, sometimes that's 2 to 3 days, and then it'll come out. But we want to make sure that you're able to tolerate ice chips and water beforehand. So we'll generally clamp that NG tube. But right now, we're going to go ahead and get started. Okay, so some of the things that you're going to need. You're going to need a chuck. You're going to need the nausea basin, just in case they decide to vomit on you. You're going to need your Salem NG tube. You're going to need your 50 to 60 cc syringe. You might need some scissors. You definitely need some tape. You can use a marker to mark the NG tube if that's what you're comfortable with, or you can make a little flag with some tape. We'll probably do both. You'll need some petroleum jelly. And of course you'll need your ears. Okay? So, we're going to do our hand hygiene. We're going to make sure we've done enough patient education, make sure he knows what the tube is for, why we're putting it, what the importance of not pulling it out. Because a lot of people will get tired of this tube and just pull it out. And it's not very fun for them going in. The first time, you definitely don't want to do it a second time because they tend to cringe and it makes it even harder. So, you're also going to need to borrow their cup of water with a straw because that makes it so much easier. So, let's put our gloves on. Alright, we are going to go ahead and let me set this over here for a second. Let's put this here so we can make sure that we don't make a huge mess in case you get sick. Here's our cup of water. Let's go ahead and set that right there. And then our tape. If you can't rip it in half, that's what the scissors will be for. You need to tear this down the middle. Okay. I guess I can't cut it. Sorry, these gloves are too big for me. It is very important that you work with the proper size gloves. Let's see if I can tear it the rest of the way. Alrighty, we got that one. And I usually do 2 additional pieces. We might have to mix that of our way for right now. Alright, so normally you would want to open the jelly, have it ready. You want to have your syringe ready to go as well. And making sure you have your little containers so that you can test your pH and your litmus strips to test your pH. Alright, so let's go ahead and pull our NG tube out. And one of the things you want to make sure that you keep track of is this little connector piece that's stuck into the NG tube. You will need this when you're connecting to your suction tubing, so don't lose it. So, when measuring, we're going to measure from the tip of the nose to the ear down to the xiphoid process. Then, of course, you're going to go further down. You're going to go from the xiphoid process to the umbilicus, and then halfway in between there, exactly halfway in between is where you would mark it, and that's how far you're going to go. For our purposes, for a dummy, we're going to go further down, okay? So, mark it. Make a little flag. My little flag, I'm not gonna wrap it all the way around because sometimes these are hard to take off and you don't want to be trying to pull at that tape when you already have the tube in place, because the last thing you want to do is pull that tube out. Okay? So, are we ready? Looks like we're ready. So you're going to put the NG tube in your petroleum jelly and get just enough on it and you're going to, with kind of gentle upward pressure, you're going to go into the nose. You might feel a tiny bit of resistance, but you do need to push a little bit harder to get through. And you're going to push down, and as you get to that like epiglottis area, they're going to start to gag. You're going to want to have them tuck their chin to their chest, because this kind of shuts off the airway and makes it easier for the tube to go down into the esophagus. And you're going to have them take sips of water as you're pushing down, and you're going to tell them, swallow, swallow, swallow. Keep swallowing. You can do it. Keep going. Keep swallowing. Hold on. We're going. Keep swallowing. Alright, swallow. We're almost there. Last little bit. There we go. So we're going to take our little flag off. We're going to make sure that we're still holding it. We're going to tape to his cheek right now to hold it in place while we test for placement. So we're going to pull our syringe out. And right now there's usually no pressure from the stomach unless you're really distended. So usually you don't really have to worry about the pinch until after you apply pressure and start pulling some in to your syringe. But if your instructor wants you to pinch it, pinch it. Okay, so we're aspirating 10 to 20 cc's or so. And then we're going to pinch it now, because we don't want this stuff all over us. And we're going to put it in our container. And then you can reconnect your syringe, and then it'll take the pressure off. We'll let this guy relax for a minute. All right, and we're going to take the litmus paper and test. And what you'd expect would be a pH of less than 5 or a bilirubin higher than 5. Just so you know, most of the time, I don't think you'll ever see litmus paper ever in a hospital. But this is NCLEX world, and this is the standard. So, the other thing is that you'll be waiting for is you will have an order for a chest x-ray, and they will come take the chest x-ray, and then you will know the placement of your NG tube, and that is also part of the gold standard. That is something we actually do. So, alright, so we already know that it's in place. What I'm going to go ahead and do is take that connector piece that I told you not to lose, connect it to our continuous or intermittent suction tubing. We're going to go ahead and pinch this off so that we can disconnect, and go ahead and connect the suction tubing. This is our makeshift suction setup. In the back you'll have a canister which everything will drain into. That's going to be connected to a pressure gauge. Then you're going to have the tubing will be connected to the canister, and so that's how they will create the vacuum inside the canister. So you will have two things that you need to control. It's pretty simple. Your on-off switch, like I said, it'll either be off, or it'll be on intermittent or continuous. Those are your only choices. Continuous means it constantly pulls stuff out. Like you'll see it go through the tube. Just keep going. Sometimes you'll need that to clear out a little mini obstruction from your line, and then you can switch back to intermittent, because intermittent suction is usually what your physicians choose. They want to pull that stuff out slowly because we don't want to set off any electrolyte imbalances. So then the other thing that you need to be looking at is the pressure gauge. You have your low, medium, and high. Normally we use a pressure between 20 to 40-ish. Sometimes you can go a little bit higher than that, but really we generally don't go above 80 when you're on low intermittent suction, because then it doesn't qualify as low intermittent suction. And most physicians don't order medium intermittent suction. So it's pretty simple. If, say, your patient needs to go to the bathroom, you are going to need to clamp. And that would be where you have the special clamp. You would pinch here, put the special clamp in right here, and then they can walk to the bathroom like that. Easy peasy. One of the things I do when I disconnect it, though, is to have a paper towel underneath, because you're always going to make a mess. Nobody's perfect at this, and until you get years and years of practice, you don't get any better, but you still make a mess. So let's reconnect him back to his suction. Say you've got a line that, you know what, it was running and now it's not. It looks super thick in your canister. Usually you see a brownish red color. If they're having gallbladder issues, a lot more times it'll be closer to green. As you get past the stomach contents, past the beginning of the small intestine contents, then you're going to start seeing things that are more greenish, more brown. And because that is stuff that's coming from the lower end of the tract. So if it's super thick and it's plugging up your tube, you are probably going to need some water. It's best to use warm water. And your gigantic syringe. You will pull whatever you can push with your holding it one hand. My hands are small, so approximately about 35 is what I can handle comfortably like that. Okay, so you'll have that all set up and ready to go. You will be pinching this. Keep it pinched. And sometimes the patient is going to help you. They're going to direct things out of their face. This will be a little bit further out. It'll be more like down here. But for our purposes, we had to make it a little shorter. So, go ahead and put it in. Say this is your fluid. Sometimes it can be air. If you don't want to do a lot of air, though. Sometimes air can be like a 1 or 2 pass only. You can do more fluid because we can suck it back out. But the air can make people really uncomfortable. So once you're connected, disconnect, and you're not going to push super gentle because you're not going to clear up your line if you do it too gentle. So you're going to push a little with a little bit more gusto, okay? And then you're going to pinch it and then reconnect it to suction, just like that. And a lot of times if you've kind of pushed what was blocking the tube out of the way, you'll see the suction coming out right away. Sometimes I've learned if you turn it up to continuous, just for a minute, you get that suction restarted and you can go back to your intermittent. Some of the contraindications for using this. You don't want to use this if somebody's been bleeding and has abnormal coagulation studies unless directed to by your GI or your surgeon. Esophageal varices is a good reason not to do this unless directed. See, other things. A lot of anxiety. Patients are going to have a lot of anxiety with this. They're not going to want it. They're going to refuse it. Part of your job is to advocate for your patient. If this is what the patient really needs, say there's a bowel obstruction, this is the treatment for that. And the only way they're going to get better and go home is to place this tube and suck everything out. So you need to explain that to your patient. Hey, you know what? I know it's not comfortable. I know it's not what you want to do, but this is the best option for you. Can we help you feel better? You know, I'll go as slow as you need to. We'll do it as fast as you need to. You know, whatever you need me to do. You know, the more you talk to them, the more you communicate what it is you're doing, the more times you're going to get them to do it. I don't think I've had anybody to date in almost 10 years continue to refuse it once I've explained everything. I've seen many nurses that don't want to talk to patients, and the patient refuses things, and it's not in their best interest. So, acknowledge their anxiety, and if it's something you can't deal with, just talking them out of it, you need to contact the physician and see if there's something you can give them to help them relax. You don't want it to be too strong, though, because if you knock them out, you're going to be trying to figure out how to do this on the side, and it's not easy. So you need a lot of help to do it on their side. If your patient is going to be here for a few days and have the NG tube in for a few days, you do want to be checking the tape around his nose to make sure that there's not any skin breakdown, okay? You know, around the nose tends to be really oily and tends to cause the tape to peel off sometimes. And then with other people, if they have really dry skin, it tends to stick really well, and you don't want to, you know, peel that skin back and take any of the skin off. So, and if it looks like the tape is coming off, you can gently remove it. You just need to make sure that you know what you're doing and you don't pull that tube out when you're changing the tape.